Good evening, everybody, and welcome to our Wound Healing Society Guidelines webinar on palliative care for pressure ulcers. This is the first in a series of webinars based on the updated wound healing guidelines that were published last year for pressure ulcers and are coming out for diabetic wounds and arterial ulcers. The moderator for our session is Christina Megal, and I will pass it over to her to introduce her. Thank you.
Well, hello, and thank you everybody for joining us today to talk about palliative care for pressure ulcers. As Kath mentioned, my name is Dr. Christina Megal. I'm an assistant professor and a nurse practitioner by background for the Medical College of Wisconsin in Milwaukee. My role, I'm the clinical director of our wound care center, and I'm very interested in hearing the presenters today talk about this topic because we were on our own journey of palliative care for different types of wounds this past year at our facility and developed some palliative care guidelines using top of licensure concepts for the nurses and the providers alike. So it's been a great journey, and I really look forward to hearing the panel provide us with our updates today. You're going to be hearing from Dr. KerriAnn Boanca. She's a home-based, she's a hospice palliative medical fellow at MedStar Washington Hospital Center in Washington, D.C. And we have Dr. Aaron Livingston. He is a home-based palliative care physician in Portland, Oregon. And we have Dr. Foy White-Chu. She is a geriatrician and a wound healing physician at the Portland, Oregon VA Center. She's also on the WHS Education Committee. Please move forward to the next slide. We wanted to share with you the name of the WHS guidelines that we're presenting a part of today. This is the title of the entire guideline, the WHS guidelines for the treatment of pressure ulcers, the 2023 update. Now, notably, this is the first set of WHS guidelines to address the issue of palliative management of wounds. So this is the section of the guideline that we will be presenting for you this evening. So with no further ado, I'm going to go ahead and hand it over to Dr. White-Chu to get us started.
Great, thank you. Briefly, before I go over this information, I want to make sure that we understand how the Wound Healing Society put together the guidelines. We do a evaluation of the different levels of evidence. And as Dr. Christina Megal mentioned that there's, this is a new portion of this guideline. So in terms of levels of evidence, you're actually going to hear mostly level 3 evidence. And we're hoping for our researchers out there that they will pay close attention because there's some really great research questions that we posed when we were putting together this particular portion of the guideline. Just as a review, level 1 is that meta-analysis of multiple randomized control trials, or at least 2 randomized control trials. Level 2 is kind of in between that and level 3, where there's some data, but not sufficient such that it would be a meta-analysis or randomized control trial. So we're going to go over as much of the strong data as we can, and also you'll find there'll be some level 3 evidence as well. So one of the things we really wanted to do for this webinar, maybe different than other webinars that we've done, is pose a question for the audience. And we want for those who are participating to just put it in the Q&A portion right in there. What is your understanding as to what palliative care is and what is palliative wound care? So go ahead and do that now. Don't be shy. This is our way of engaging you guys.
So we have one comment in the Q&A section. One of our members or participants has mentioned What is palliative care? Treatment based on comfort, not intended to be curative.
And then what about distinguishing from palliative wound care? Any other thoughts in the audience from that? Well, I'm going to go over the principles that we're going to focus on today. We will present some cases of people that do have serious life-limiting illnesses, and I think that's a big take-home here. And Dr. Livingston, on the next slide, when we get there, we'll go more into this, of maybe an old concept of palliative care and more of a more modern concept of palliative care. But with respect to palliative wound care or wound healing, this is an emerging field, especially with regards to pressure ulcers, and we are focusing similarly to what the participant said, is relief of wound symptoms and suffering in the context of a serious illness. And we recognize that immobility, frailty, especially in our older adults, puts them at high risk for pressure ulcer. So the goal is to pain, infection, odor, while balancing the priority comfort-focused care. But keep in mind that even people who are in a serious illness, but when we're taking care of them with regards to their wounds, we might be focusing on a more palliative component, while the other team members are focusing on curing the patient or helping them recover from that serious life-limiting illness to where maybe they might have a new baseline or even fully recover, that is possible. And that's all on our preamble and our guideline where you can read further. Dr. Livingston is going to now discuss more about palliative care.
So palliative care focuses more on a holistic assessment of needs and goals, managing symptoms to ameliorate suffering, and making sure that the care that patients are getting aligns with the patient's goals. So on the top here, you see the sort of the older concept of what palliative care used to be, where patients would be going through curative intent. They would hit a transition point and transition into palliative care, then to hospice, and then pass away. There's more of a newer model where palliative care is sort of part of the entire care that a patient is receiving while they're still getting curative intent. And then the more supportive palliative care takes on more and more of a role as the disease progresses. So a typical palliative care patient is a patient living with a serious illness, COPD, CHF, cancer, usually with a significant symptom burden of their disease that can be managed or worked on by palliative care providers. Next slide, please. So when we talk about palliative wound care, there's a little bit of a change in focus. We're not only focusing on just prevention and treatment of a wound, but also the symptoms and other things related to it, like odor, which can be very stigmatizing or isolating for a patient, and then the pain that is around that, either condition or the wound itself. Next slide. So we'll start by talking about an inpatient palliative care patient. This is Mrs. P. She's an 86-year-old female with dementia, type 2 diabetes, breast cancer, status post-mastectomy with mets to the bone, and obesity. She was found down in her home after an unknown amount of time. At baseline, she is incontinent of stools and urine, fully dependent for all her ADLs, including hygiene. She's brought to the ED, found to be septic, placed on pressors, and admitted to the ICU. At this point, she remains completely unresponsive. She's intubated on mechanical ventilation, stable in epi, has a Foley, and she's getting IV fluids, but no other nutrition. The ICU doctor notices that she is on clinic palliative care for her cancer pain, and her last stated goal in their note is that she would like life prolongation and to continue chemotherapy. The ICU provider contacts a palliative care provider, and asks about pain management, and the provider mentions that he's worried about Mrs. P developing a pressure ulcer. So the first sort of question is Mrs. P at risk for a pressure ulcer? And as many of you probably know, ICU patients are 4 times more likely to have skin issues than in other units. And intuitively, you probably know, well, yeah, this patient's going to be at high risk for a pressure ulcer. They're immobile, they're on a ventilator. But how can we truly assess their risk? Next slide. So there have been 2 scales that have been validated for determining risk of a patient for pressure ulcers in the ICU with serious illness, and that's the Braden scale and the Jackson-Cuban scale. But the Jackson-Cuban has been shown to have a higher predictive value, so it's the one that should be used. And if you look at these categories, you'll see that they're based on pretty common sense things that everyone knows that pressure ulcers are caused by things that restrict mobility. So anything that restricts mobility or functional status coming in is going to have a worse or a higher risk of a pressure ulcer. So you can see that the categories are age, weight, general skin condition, mental condition, mobility, hemodynamics, respirations, nutrition, incontinence, and hygiene. And these are all scaled on a scale of 4 to 1, 4 being less likely to develop a pressure ulcer, 1 being more likely. So if we just take the example of mobility, somebody who's fully walking has a lower risk of a pressure ulcer than somebody who's immobile and on bed rest. So if we take our patient, we know she's over 70, so that's a score of 1. She's obese, score of 3, and so on. I won't bore you with going through every single thing, but that gives us a total score of 21. And the cutoff for this is 24. So anything lower than 24 is at high risk for pressure ulcer. So we can now say, using our level 2 evidence and using the scale, that this patient is at high risk for a pressure ulcer. So now that we know that she's at high risk, I'll turn it over to KerriAnn to discuss ways that we can prevent these pressure ulcers.
Yeah, thanks, Dr. Livingston. So now we have another question for the audience. If you guys want to put some stuff in the Q&A. Now that we know that our patient is high risk, how do we prevent pressure ulcers? Feel free to just put any thoughts there in the Q&A.
Kaylee has provided the thought of using different offloading techniques to help prevent some pressure injuries.
Yeah, great thought. We'll go ahead and go to the next slide and discuss. So one of our other guidelines talked about reactive support surfaces. Patients living with a serious illness who are at high risk for pressure ulcers should be placed on a reactive support surface. A standard hospital mattress or home mattress is not sufficient for pressure ulcer prevention. We know that patients living with serious illness are at higher risk. They may be considered for something like an active pressure reducing support mattress. And sometimes this can allow for less frequent turning, which can promote comfort, one of the goals of palliative care. There are a lot of different support surfaces out there, a sample of them here. You can see some static air mattress overlays, foam mattresses, low air loss support surfaces, or the more high-tech ones, which are active alternating pressure mattresses. The aim of these, of course, is to redistribute the pressure to minimize excessive pressure on one particular spot on the body. And this is not unique to patients with serious illness, we all know. There's strong evidence in the literature to support this practice for all patients who are at high risk, but it's especially important because many of our patients with serious illnesses are at especially high risk, as we just kind of saw with Miss P. And as I mentioned, sometimes the use of an active pressure relieving support surface can allow for less frequent repositioning. Depending on the patient, If they have symptoms that come with repositioning, such as pain or dyspnea, you may be able to reduce the frequency of turns from something like every 2 hours to every 4 hours if they're on an active support mattress. Some studies indicate differences between the varying surfaces, but for patients with serious illness, selection should really be based on availability, cost, and prognosis. So on the next slide, we'll look at a sample of the evidence that did make this level 1. This came from a very large Cochrane meta-analysis. There are also a couple of other systematic reviews that we cited in coming up with this guideline. But this specific force plot came from that Cochrane review. It was published in 2021. They looked at all different types of support surfaces. And as you can see here, they did a comparison of different types, and the reactive air surfaces, the alternating pressure surfaces, and reactive gel surfaces all showed a reduced risk of pressure ulcer development compared to foam surfaces. So this level 1 evidence, while this looked at all patients, all types of patients, we felt comfortable kind of extrapolating this to care of patients receiving palliative care, because we do know that most of the time they are at especially high risk of skin breakdown. So now Dr. Livingston will discuss how nutrition may impact pressure ulcer prevention.
Just like other patient populations, nutrition status is a significant factor for preventing and treatment of pressure ulcers. And reaching the nutritional goals is a protective factor in seriously ill patients in the ICU as well. So the sort of change, or the more recommendation for this serious illness population, is that they have daily nutritional assessments to make sure that they are reaching their nutritional goals. And that's because patients who are in the ICU, about half of them actually achieve the nutritional goals that are set. And that's because they're at very high risk for frequent interruptions for procedures, diagnostics, testing, sedation, no route to feed. So there's a lot of different things that sort of play into it. Also, critically ill patients that come in may already come in a calorie deficit or other nutrient deficits. So it makes it important to get the goals back in. There's some limited preliminary data that suggests that if a patient reaches the nutritional goals in the first 72 hours in the ICU, that it may mitigate the risk of a pressure ulcer formation, but more research is needed to sort of develop that and figure out exactly what protein and calorie targets we should be going for. Dr. White-Chu will now talk about preventative dressing.
Thank you, Dr. Livingston. Right, so there's actually really robust level 1 evidence of using a prophylactic dressings over bony prominences for those in the intensive care unit. So here's some examples here. Foam dressing with a silicone backing, and it's multi-layer foam. I know from personal experience that this has been extrapolated to the nursing home and even hospice care level. And I wouldn't totally discourage that, but just keep in mind that the evidence is in the ICU. These dressings also tend to be more expensive, but then you can argue that a pressure ulcer is extremely expensive. So that's why in the next slide, we're going to talk a little bit about when we were putting this guideline or this recommendation together, there was an article, granted a little on the older side, but did a robust look at efficacy and cost benefit analysis. So these were soft silicone dressings, like I showed you in the photo before, looking at preventing sacral and heel pressure ulcers. They looked at 440 critically ill patients in an acute care hospital. They were randomly allocated to either get those prophylactic dressings and changed every 3 days, or a control group where they got standard care of frequent turning and repositioning, and both of them also got that. So what they found is that there was a significant reduction of pressure ulcer incidence in the intervention group, which you see here on the left. And this was a study that was done out of Australia. So when they were looking at these dollars, they did a certain dollar amount per person based on an intention to treat analysis. But you can see, when you look at, wow, stage 1, 19,000 and the control, well, that's because there were so many stage 1s that happened. And if we think about how pressure ulcers happen, it's just the tip of the iceberg. I also get nervous because we do know that sometimes stage 1s may actually be deep tissue injuries if it's not appropriately staged, that people may call that non-blanchable erythema, when in fact it might be something more serious. So anything we can do to prevent that damage in people who are seriously ill in the ICU, these dressings are the way to go, and they save the hospital a lot of money, and they save your patients a lot of heartache. Whether that could be extrapolated to more the outpatient setting remains to be seen, and is a great research question. And if your particular facility has the resources, it might be something to consider for prevention. Here we have what we want to talk about, changing priorities ahead. So kind of giving you a warning shot that Mrs. P is not doing well. So our priorities might be changing. Take that away, Dr. Boanca.
Yeah, thank you. So an update on the next slide of Miss P's progress. She's a little bit more alert, but still remains in the ICU receiving critical care. And she's noted now to have a new stage 2 pressure ulcer on her coccyx. Miss P is alert enough to be able to refuse being repositioned, which was recommended to prevent worsening of her pressure ulcer. And we have another question for you all if you want to put anything in the Q&A. In regards to her care plan for her pressure ulcer, how might we change what we're doing for her? Give that another minute, see if anybody has a thought, but can move on whenever you're ready, Dr. White-Chu. We'll go on to talk about our next guideline, which is about repositioning, and specifically positioning based on goals. So for patients receiving palliative care, repositioning and turning frequency ought to be in accordance with their individual goals, comfort, and tolerance. So turning should occur on a flexible, individualized schedule. Many patients who are facing a serious illness may prefer a single position for comfort, especially when actively dying. So, of course, when possible, it's recommended that standards for pressure ulcer prevention and treatment with turning to offload pressure at regular intervals should be employed. However, as I mentioned, sometimes the goals of comfort and minimal disruption will take priority, and we should be aware that for some patients with a serious illness, there are conditions that could impede standard pressure ulcer prevention, such as incident pain or pain on movement, pathological fractures, having dyspnea on movement, or autonomic instability for a patient who may be nearing end of life. So these may be reasons why we adjust our turning frequency. It's important to ensure patients and families are educated about the rationale for frequent repositioning, but clinicians should also recognize that patients and families may choose to prioritize comfort and accept the potential risk. So we recommend using a shared decision-making model and to really document in the medical record what's been decided from that conversation so that other people who are caring for that patient can see. And also to talk with our nursing colleagues to make sure that that plan takes place if there are any adjustments to standard inpatient practices. So for Ms. P, after a shared decision-making conversation and her acceptance of the risk of worsening her pressure ulcer, her comfort may be prioritized and turning frequency reduced, especially if it appears she's nearing end of life there in the ICU. An alternative for Ms. P could be to address her pain, which takes us to our next guideline. Go to the next slide. So we talk about pre-medication for turning. With use of an analgesic or sedative medication, This may allow for more frequent turning and skin care for those who have significant pain with position changes. Now, this does need to be balanced with the potential for sedation, which can impede spontaneous movements, as well as an individual's goals for interaction with others. So, as I mentioned, incident pain or pain with movement can definitely be exacerbated by needing to reposition for pressure ulcer prevention or management. And sometimes it may still be the best thing to do for that patient to offload pressure. And so in those cases, it's recommended that individuals receive pre-medication with an analgesic or a sedative about 20 to 30 minutes before the planned turn. Like I mentioned, this can reduce spontaneous movements in bed, which often allow for minor shifts in pressure. So just something to keep in mind if we are going to use a medication for pain. And additionally, sometimes patients will say that they don't want pain medications if they are more alert and engaged so that they can maximize time awake. And so that definitely should be taken into account as you think about using medication before turning. And of course, we would still apply guideline 8.3 and talk with the patient and family about their goals and make sure that we document this well. In addition, we would take into account prognosis. So a patient who may have days left likely won't benefit from repositioning for pressure offloading, whereas a patient who's has a prognosis of more like months, might benefit from repositioning. So with all of these things, help us care for Miss P in accordance with her goals and comfort in mind. Now, Dr. Livingston will continue with Miss P's story.
So Mrs. P's pressure ulcer continues to worsen, more painful, and now requires debridement, which she refuses, saying, "Dressing changes are already painful enough. I don't want to go through that." She states that she no longer wants to continue with treatment and she just desires to go home. The next slide. So part of good palliative care is making sure that symptoms are properly palliated. And doing that, to ensure good pain care, you have to assess pain. And it's important to assess pain at every visit, every intervention, and change to make sure that you're fully palliating the pain. So as previously mentioned, it's important to pre-medicate for things like dressing changes and then assessing that you're fully addressing the pain. Now, it's important to remember in this patient population that they may have pain for other reasons as well that still require palliation, like dyspnea, cancer pain, anxiety around dressing changes, or their condition. So it should come as no surprise, but research shows that the best indicator for a patient's pain is patient reporting their pain. So what do you do if your patient cannot communicate, either has cognitive issues or is incapacitated? So there are other methods of assessing their pain. There's the Wong-Baker-Facey scale, which you see here in the picture, which can be used. And this was originally developed for pediatrics, but has been validated in other patient populations. And you simply explain the patient scale to the individual. 0 being no hurt, 2 a little bit more hurt, so on up until 10, which is more pain than you could ever imagine. And then allowing the patient to either point to or state a number to get a good idea of what their pain is. There's also visual assessment scales and other things you can use to validate a patient that is completely incapacitated or unable to communicate with you. But it's important to keep in mind that good, proper palliative care, palliative wound care is making sure you're assessing the pain so you can properly treat it. I'll now turn it over to Dr. White-Chu to talk about procedural related pain.
Thank you. So this was one of our guidelines that had more of that in between level 2 evidence. And I really want to go over, some of our non-pharmacologic options for treating procedural related pain. And when we're talking about procedures, a lot of people think it's debridement. but also, frankly, dressing changes. Those can be very painful to patients. And I'm also constantly asking, well, what exactly is the pain? Is it the removing of the tape, or in the case of negative pressure wound therapy, is it removal of the drape, removal of the foam, removal of the dressing? Is it being left open to air? So this is a common phenomenon where people have significant pain when the wound is being left open to air. So being cognizant of those details and really getting into a great history can help facilitate your treatment of the patient and alleviate their pain. I am really big on what's called timeouts, or making sure the patient knows they are in control. So if we are doing any kind of procedural related pain with regards to dressings or debridement, I tell them, you tell me if you're having pain and we need to stop, and you stop, as opposed to going, oh, it's just a little bit more now. No, make sure you keep to your promise of that the patient's in control. Soaking dressings with warm water, if you have the ability to do that, so it is, that warmth. There's something about, like I mentioned before, the air hitting the area, cooling it down, and causing potentially maybe some vasoconstriction, and that contributing to the pain. Edema is a big one. Edema is painful. Swelling is painful, and I tell patients that. So trying, if there is compression that can be safely done, you feel confident that there are arterial diseases, that they don't have arterial disease, or that it's fine for compression, and managing that swelling can really go a long way with regards to pain management for those lower extremity wounds. You see a picture here of topical lidocaine, and that is a commonly recommended formulation for any kind of procedural related pain. I even prescribe it for dressing changes for home health or for caregivers to do. There is some conflicting data as to whether it actually causes poor wound healing. But if the goal, again, right now is to optimize pain management, and it means that they can get a regular dressing done, then that might supersede things to where you could see some healing or definitely some palliation of that wound. Solution is much more fast acting than the gel formulation. So in our clinic, and as I prescribe as an outpatient, we do prescribe the solution formula, and a 4%, just like you see in this photo. One of the studies that we looked at to guide this particular guideline was a systematic review that looked at, and they put together a risk stratification, low risk, high risk of pain factors and risk factors that they found. I don't want to dwell so much on that. I think what was more important were all the different ideas that they had with regards to different interventions. In my clinic, we don't administer opioids. If our patients are on opioids, whether it's regard to wound pain or other factors, and they have a lot of pain around treatment, then we will recommend that they take it probably within half an hour to an hour before their visit. But definitely I have prescribed acetaminophen, rarely NSAIDs, mostly because, as I mentioned, I'm a geriatrician, so a lot of my patients are older and frailer, so I need to be careful with their kidneys. But again, would prescribe a topical lidocaine. EMLA is another formulation in a cream. It's a prilocaine lidocaine formulation. And then all the non-pharmacologic treatments, which are really, really important, and we should not forget. So this was a great study to kind of help guide this guideline to give all these different ideas. And now we're going to go to case 2.
Yeah, so we will discuss the care of Mr. F, who's a patient receiving home-based palliative care. You can go to the next slide and learn a little bit more about him. Mr. F is a 73-year-old male. He's got many medical comorbidities, which include dementia and COPD. He's been on home-based palliative care for a number of months now, just for management of his dyspnea related to his COPD. He's continued to have decline and is losing weight. So the family wants to know if he's at high risk for a pressure ulcer. We wanted to ask you, and if anybody wants to put something in the Q&A, what do you want to know to determine Mr. F's risk? Somewhat similar to things we've discussed before, but curious if there's anything else you would want to know about him.
we have a question from Kaylee. She would like to know what is his mobility like?
Yeah, that's a great question. Yeah, so Dr. Livingston will now discuss further about risk assessment in palliative care patients.
So, as you can probably imagine, there's not a lot of robust research on patients with serious illness at home, in home-based palliative care and hospice, just given the difficulty of assessing that patient population. But there is a scale that's been consistently used and well validated in the palliative care world, and it's called the Palliative Performance Scale, which you see here. There was a study in 2008 that compared the Braden scale, which is one used in the ICU, to the Palliative Performance Scale, and they were found to have similar predictive values for pressure ulcers. So a few other studies have sort of weighed in, all sort of lower evidence, which is why this is a level 3, but it gives you a sort of baseline assessment of whether this patient is at high risk for a pressure ulcer or not. And you'll notice that the Palliative Performance Scale shares a lot of similarities to the Jackson-Cuban scale. We're talking about ambulation or mobility, as somebody brought up. You know, what is their self-care like? What is their nutrition, their intake like? So looking at the Palliative Performance Scale, this is a left-focused thing. So you always start at the left side. So for argument's sake, let's say that our individual is wheelchair bound, mostly sit, can stand and pivot. So that would put him at a Palliative Performance Scale of 50%. So then we go to his activity level of disease and can't do any work, so we stay at 50%. Self-care, family's taking care of all of his needs, so he's a total care, which drops him down to a PPS of 30%. Then he's having reduced intake, keeps him at 30%, and the level of consciousness is full, he's alert, he's interactive, but we don't ever move back up as we move across, so he'll stay at 30%. And since he's at the cutoff of 40 or less, this puts him at high risk for a pressure ulcer. Next slide. So since we now know that he's at high risk for a pressure ulcer, what type of things can we do to prevent or reduce his risk of a pressure ulcer? We want to go ahead and put them in the chat. I'm going to assume that people put in things that we've already talked about: positioning, reactive bed surfaces, dressings, nutrition. Same as you would for an inpatient population, you try to do those things at home as best you can as well. So next slide. So the first question we have is, what about nutrition? So a little bit more about Mr. F. He has lost the ability to swallow. He can't even take sips of water. The family adamantly wants a feeding tube or TPN for Mr. F to allow for a better nutritional status, to prevent a pressure ulcer, and extend his life. So should artificial nutrition be offered in Mr. F's case? Next slide. So this is a level 1 evidence based on a Cochrane review that looked at 14 different controlled studies and looked at the outcomes of different groups with dementia at different stages and whether artificial nutrition would help with prolongation of life and quality of life. So things like pressure ulcers and other related symptoms. So it ended up being a collection of about 37,000 participants with a PEG tube, sort of looking at different rates of survival. And this, you'll see that there's a lot of sort of conflicting data in there as to whether, you know, PEG tubes reduce the risk of pressure ulcers, PEG tubes versus NG tubes versus TPN. And next slide. All of this gets a little bit confusing, and it's a particularly difficult time because families in advanced cases of dementia like this, it's families that end up taking care of the patient, and they're deciding whether they should have feeding tubes, and they're really pushing for things. What they don't really seem to or what people don't tend to realize is that with dementia, feeding tubes can often cause a lot of problems as well. So things like pneumonia, worsening of bladder control, which can lead to worsening pressure ulcers, bleeding, swelling, infection. And then, of course, just the confusion around dementia or serious illness, they may pull out the tube or try to remove the tube. So now that I've just said that we have this data, but it's very confusing, what do we do with it? There's sort of two good guidelines that have been well established through the literature to follow. And that's that if a patient has advanced dementia, then they should not be provided a feeding tube because it does not lower the risk of mortality, decrease pain, or improve quality of life. And the big thing that families often get stuck on is they think that it will decrease the risk of aspiration, and the feeding tube does not actually do that. Also, if a patient is within the last month of their life, or predicted to be in the last month of their life, the feeding tube can actually cause more harm than good. So particularly causing things like tissue edema, diarrhea, or overall discomfort. So generally, if someone is entering into the last month of life, would not start artificial nutrition. I will now send it over to Dr. White-Chu to talk about Mr. F's progress.
Thank you. Okay, so now Mr. F is potentially more in the bed, less of a wheelchair user and staying in the bed now. A decision was made to bring hospice into the home, and he does develop a sacral pressure ulcer despite all that was done to try and prevent this. Family makes sure that his pain is well controlled. He's repositioned as he tolerates. Family's still concerned, though, about if he's embarrassed or they're embarrassed by the odor, as there's other family from out of town that want to come see him, but they're like wondering, well, what about this odor as soon as you come in the room? So what can we do to decrease that odor? Well, what's the odor from? The odor is from anaerobic bacteria by and large. And there is level 3 evidence of use of certain topicals, whether that's cleansing with Dakins, which is a dilute bleach formulation, using airtight secondary dressings such as charcoal dressings, topical metronidazole. Keep in mind, though, that the gel form contains alcohol and that can cause pain. Also just using antimicrobial dressings, ones with silver, cadexmer, or iodine. And then there are these other tricks that I've learned over the years of putting oil of peppermint or a diffuser in the room, kitty litter, coffee grounds. So when we're using antiseptics, they do kill the anaerobes. They can also cause cytotoxic or be cytotoxic to the cells. So if you're seeing any kind of improvement, just keeping in mind, what's your goal? Is it the odor that's the goal, which it is in Mr. F's case, or is it more that you want some healing? So if odor becomes a problem for your patient, then maybe temporarily you'll use some odor control with such the Dakins formulation, but then switch off of that as you're wanting to do more healing if their goals are different. My only concern about charcoal activated dressings is they tend to be kind of pricey. So just bearing in mind whatever it is that the patient's insurance coverage might do. I also really have found great results of just taking metronidazole tablets, crushing and sprinkling. This is probably the cheapest way to use metronidazole and can be easily obtained from any pharmacy. A little caveat, beware the malodorous hydrocolloid. Those are dressings that are sometimes used for stage 1 and stage 2 treatment, and can be very malodorous when you remove them. And so now we're going to go to Dr. Boanca to talk to us more about
Yeah, so Mr. F on hospice dies peacefully at home. And one thing we wanted to wonder about with you all is whether this sacral pressure ulcer was preventable, or was it skin failure, something expected? If you have any thoughts, you can put it in the Q&A, and we can share our thoughts on this too. There's considerable debate about this. That's okay if you don't have thoughts, but we can go ahead and move on to our next slide. So our final guideline in this section was talking about this issue of distinguishing pressure ulcers from unavoidable skin failure when a patient is at end of life. And of course, this topic is relevant to our patient population. And there, like I mentioned, there's kind of a fair bit of uncertainty in the literature as to what to call this and how to think about it. As we've mentioned throughout the presentation, critically ill individuals and those at end of life are prone to increased skin breakdown. And there have been multiple kind of different names used. You'll see them here: the Kennedy terminal ulcer, skin changes at life's end or scale, the Trombley-Brennan terminal tissue injuries, to kind of designate this skin failure. And the skin, like any other organ, can fail. It can be part of a multi-organ dysfunction syndrome or just as part of the dying process. And so in general, this change is not considered the same as an avoidable pressure ulcer, but rather an expected change and sometimes is unavoidable. But there's no current diagnostic criteria for this. And it has been the topic of some legal disputes regarding hospital prevention of pressure ulcers. There was a 2022 survey of many wound healing clinicians, which reached 80% or 85% consensus that the KTU scale, TB, TTI, and skin failure at end of life are unavoidable and not attributable to substandard care. The same survey, though, found a lack of consensus as to whether pressure ulcers are part of this skin failure. And right now we don't have any validated risk stratification scoring for skin failure the same way we do for pressure ulcers. So it's definitely an area of needed more research to determine whether this skin failure can be prevented, things that we can do for management of it, and classifications, how to think about it. So with all of that, we will conclude now with some takeaway learning points. So as we've mentioned, palliative care is support for a patient during a serious illness. It doesn't necessarily mean a terminal illness, so that does encompass those patients. And palliative wound care is much like all pressure ulcer care, but with special attention to patients' comfort and priorities. There is some high-level evidence that exists to support palliative wound care, but certainly a lot of research question opportunities still exist in this emerging field of palliative wound care. So we thank you all for your time listening, and we'd be happy to answer any questions.
Thank you, everybody, for your engagement during the session today. The Q&A is open. We would very much enjoy if you would share any of your thoughts or questions with us while we still have the panelists available to open up discussion. I'd like to pose a question to the group while the others are thinking a bit. One of the topics that was covered throughout the presentation with both case studies is that pain management concept. So we have the options of topical pain management choices, we have oral pain management choices. When you have someone who is in that continuum that Dr. Livingston so beautifully highlighted on one of his opening slides, how is pain managed across the continuum of that palliative care? Is there usually a central practice that guides that therapy? What does that look like in different practices?
I think that question's for you, Dr. Livingston.
Anybody willing to tackle it?
I think that's fair. I think it usually comes down to a combination of different techniques to try to get pain under control. But as we sort of talked about it really depends on the patient's goals, their overarching goals when it comes to the pain management, because you could always make somebody pain-free, but they may not be conscious and interactive with the family, which may not be really dictated on what they do. And there's the WHO scale of pain control, which you sort of like move through the opiates and different things like that. But it also sort of depends on what's available, right? So like in the hospital, you can use things like ketamine and IV opiates to help with the pain management, where at home you may be more reliant on other topical things or oral management. So that's my way of saying there's not like a definitive guide for it, but there are always ways or things that you can try to get their comfort within their goals.
And for those folks who are being managed in the home, is that part of a hospice palliative care team, or are you finding that it's being managed by a multitude of different providers?
In my experience, it ends up being a multitude of different providers. It's you have wound care specialists who are dealing with the wound, and then you have a palliative care specialist who's dealing with the pain around that wound. So it gets very divided into who's managing what, but a lot of communication back and forth to make sure that everyone's on the same page.
Sure. Thanks, Dr. Livingston. Yeah, these are complicated situations, no doubt. Another question for the group. In your different clinical experiences, have you, speaking in generics, have you found any particular type or classification of dressings that have contributed to more pain and more comfort for patients over other types of dressings?
I think that's a Dr. White-Chu question.
Sorry, I thought she was still asking Dr. Livingston. Do that one more time for me.
So the question is just, in your clinical experience, have you come across any particular types of dressings, not looking for brand names, but just looking for like more of those generic categories, any particular types of dressings that have provided a higher level of comfort during dressing changes for patients?
Yeah, I think that's great. And because I was about to go into that, and then I didn't want to get too off course when I was talking about it. So when it comes to, for instance, like I mentioned, if it was tape removal or drape removal from negative pressure wound therapy, using a skin adhesive remover is key, because it can go through the drape and through the tape, and that can make it very easy to remove. And then before you put it down, putting down a skin protectant. So that's like a transparent film that it leaves on the skin, that it can not stick directly to the skin. The other challenge, though, we do tend to use a lot of silicone-based dressings. They tend to be gentler. They also tend to come off easily. So, there's a pro and con with that, but using that and those types of foam dressings can be very helpful. I think also every time you assess the wound, determining, are you having to scrub a lot of wound product off? Is the wound product drying up in there? Then you need to change what you're putting on it so that doesn't happen, because that type of friction definitely hurts with any dressing changes.
Nice. Yeah, we found some success with different types of oil emulsion dressings and those whatnot, so you don't get that adherence that ends up pulling later on. But yeah, thank you. Thank you for sharing.
I think I see Kaylee Stanko's hand up. I don't know if they had a question.
Kaylee, if you have a question you'd like to ask. Oh, she put her hand down.
Sorry.
False alarm. She said, sorry about that. No problem.
I will add, can I add a little bit to what Dr. White-Chu just said about
Please.
in the home population? What I see a lot is that families trying to do their best just to keep wounds covered will often have too tight of compression. They'll like go to the Coban or things like that on the heels, and it just ends up causing a lot of pain and discomfort. So really educating families is key.
Yes, definitely. Well, we have no further questions from the group at this juncture.
Okay, great. Thank you, everybody. Thank you for interesting and interactive presentation. And thank you to our attendees. So for all of you here, to let you know, this webinar has been recorded and it will be available for WHS members on the Wound Healing You section of our website. And in a few more weeks, it will also be available for everybody on YouTube on the Wound Healing Society channel. I don't have the link for that, but it can probably be accessed via the website. So thank you all. Good night from the East Coast and good afternoon from the West Coast, I guess.
Thank you.
Bye all.